नमस्ते बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JV'n Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, at Faculty of Homeopathic Science in JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to discuss about non-Hodgkin's lymphoma. In the previous lecture, we have discussed about Hodgkin's lymphoma, and now we are going to discuss about non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma is a heterogeneous group of malignant disorders that is characterized by replacement of the normal lymphoid structures by diffuse and nodular collections of abnormal lymphocytes. Non-Hodgkin's lymphoma represents a monoclonal proliferation of the lymphoid cells of B cells that is 70% or T cells that is 30% origin. The classification of non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma are classified as low or high grade tumors on the basis of proliferation rate. Low grade tumors are divided slowly and may be present for many months before diagnosis and typically behave in an indolent fashion, but is not curable by conventional therapy. High-grade tumors divide rapidly and are typically present for a matter of weeks before diagnosis and may be life-threatening fatal if untreated, but is potentially curable. So we have low-grade tumors and we have high-grade tumors. Now the etiology. The etiology of non-Hodgkin's lymphoma is unknown, and a number of environmental factors have been implicated in the occurrence of NHL, including infectious agents, chemical exposures, and medical treatments. The infections of bacteria, that is H. pylori, viral Epstein-Barr virus, HTLV, that is human T-cell lymphocytic viruses. There is immunodeficiency with immune suppressive therapy, HIV, autoimmune disorders, ionizing radiations, and carcinogenic chemicals. Incidence. It is more frequent in the elderly and the incidence increases with age. 62.8 million population per annum at an age of 75 years. It is more frequent in men. The patient with both primary and secondary immunodeficiency states are predisposed to development of non-Hodgkin's lymphoma. Now the clinical features of non-Hodgkin's lymphoma. In NHL, there is painless lymphadenopathy that is often widespread and not contiguous. Constitutional symptoms like fever, sweat, anorexia, and weight loss is there. Respiratory symptoms like pleural effusion, mediastinum node enlargement, parenchymal lung involvement, and there is involvement of the other sides like skin mycosis, fungoides, tonsils, and adenoids with salivary glands, GI tract, testis, etc. There is extranodal involvement that is more common in T-cell disease and involves a bone marrow, gut, thyroid, lung, skin, testis, brain, and more rarely bone. There is hepatosplenomegaly that can be present. Now, there are various investigations that could be done. There is routine bone marrow aspiration and triphium. Immunophenotyping of the surface antigens to distinguish T and B cells tumors. There is immunoglobulin determination, which some lymphomas are associated with IgG or IgM paraproteins, which serve as markers for the treatment response. Measurement of the uric acid levels may show some very aggressive high-grade non-Hodgkin's lymphomas are associated with very high rate of urate levels and HIV testing. The other investigations includes hematology with normocytic normochromic anemia, leukoerythroblastic anemia with bone marrow infiltrations, hypersplenism, neutropenia and thrombocytopenia, and raised ESR and C-reactive proteins. The management of non-Hodgkin's lymphoma consists of the following. In low-grade lymphoma, we have to wait and watch, but asymptomatic patients may not require therapy. There is indication for treatment that includes marked systemic symptoms, lymphadenopathy, causing discomfort or disfigurement, bone marrow failure, or compression syndromes. There is radiotherapy that can be used for localized stage disease that is rare. Next, management consists of the chemotherapy that is seen in most of the patients will respond to oral chemotherapy with chlorambucil. Monoclonal antibody therapy, that is humanized monoclonal antibodies or the target surface antigens on the tumor cells and induce tumor cell apoptosis. Rituximab in combination with cyclophosphamide, vincristine and prednisolone (RCVP) is recommended as the first-line therapy. Bone marrow transplantation with high dose of chemotherapy and bone marrow transplantation in patients with relapsed disease. Now, the management of high-grade non-Hodgkin's lymphoma. It required treatment at the initial presentation. Chemotherapy, the majority with greater than 90% are treated with CHOP regime, that is cyclophosphamide, doxorubicin, vincristine, and prednisolone. Radiotherapy is indicated for a residual localized site of bulk disease after chemotherapy and for spinal cord and other compression syndromes. There is monoclonal antibody therapy when combined with CHOP chemotherapy. Rituximab R increases the complete response rates and improves overall survival. Bone marrow transplantation, that is autologous bone marrow transplant, can be done. Now the prognosis of non-Hodgkin's lymphoma. Low-grade NHL runs an indolent, remitting, and relapsing course with an overall median survival rate of 10 years. Transformation to a high-grade NHL is associated with poor survival. In high-grade NHL, some of the 80% of the patients overall responds initially to the therapy, but only 35% will have disease-free survival of 5 years. Now, there is an international prognostic index for non-Hodgkin's lymphoma, which includes 5 clinical risk factors, that is, age greater than 60 years, serum lactate dehydrogenase or LDH levels are elevated, performance status is greater than 2 ECOG, that is Eastern Cooperative Oncology Group, an Arbor staging of 3 or 4, and greater than 1 site of extranodal involvement. Patients are assigned a number of each risk factor they have, and patients are grouped differently based on the type of lymphoma. For diffuse large B-cell lymphomas, in grade 0-1 factor, there is low risk with 35% of the cases having 5-year survival in case of 73% of the cases. When the factor 2 is there is low or intermediate risk with 27% of the cases with 5-year survival and 51% individuals. 3 factors with high intermediate risk of 22% of the cases with 5-year survival and 43%, and 4 and 5 factors with high risk, that is 16% of the cases with a 5-year survival rate of 26%. For diffuse large B-cell lymphoma that is treated with R-CHOP regime, 0 factor is having very good prognosis with 10% of the cases, and 5-year survival is there in 94% of the cases. 1 and 2 factors is good prognosis with 45% of the cases, and 5-year survival is 79%, and in 3, 4, and 5 factor, the prognosis is poor. With 45% of the cases, 5-year survival is less than 55%. So this is basically all the disorders that are commonly seen in case of lymphomas. These are the total lymphoma cases, 100%, in which we have non-Hodgkin's lymphomas in 62% of the cases, and we have plasma cell disorders in 16%, CLL in 9%, Hodgkin's in 8.2%, and ALL in 3.8% cases. So this was all about lymphomas. This completes the chapter of hematological disorders. In the next lecture, we are going to start with the cardiovascular system. This session was powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University, I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and I'll try to resolve. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow. Thank you.